Good afternoon, everyone, and thank you for joining us today for the Steward Hospital bankruptcy case Demystified. Couple of public service announcements are that for ABA purposes, and I guess probably for in-the-room purposes as well, this is a non-CLE program. And for those that are attending remotely, there is an opportunity to include a question on the Q&A, or I'm sorry, on the chat function. Is that what it is? Feel free to include that, and at some point, hopefully, we will be able to pull those questions up. In the room, what the panel has decided is, although we usually hand out paper and ask you to write out your questions, they don't want you to do that. These are tried and true trial lawyers, so they're happy for the yell out your questions and put your hand up, though. Maybe that would be fine, and we'll call on you. And I hope everyone will be able to hear that. Sounds like yes. Okay, so this is, in fact, of course, a hybrid webinar. And I want to recognize that it's brought to you jointly by the Pioneer NELF, which is a public interest law firm based here in Boston. I'm the president of Pioneer NELF. I'm also active in the American Bar Association, and the ABA is the other sponsor of today's event. That would be the Business Law Section's Business Bankruptcy Committee. I want to recognize and thank the law firm of Sullivan & Worcester for hosting us today, especially the partner, Joel Carpenter, who is a member of our board. I thank Joel for his support of everything Pioneer. I also want to recognize at the ABA Business Bankruptcy Committee level, our fearless leader, Henry Cavane. Henry's at the Pajolsky firm in California. And at a time when organized bar associations are having a hard time recruiting young folks and I guess old folks to continue to be members. Well, Henry, through his leadership, we just continue to add more bankruptcy professionals to the Business Bankruptcy Committee. So it's a high quality opportunity for anyone who's interested in not only the programming, but also in the networking. What we're going to do today is I'm going to give a little background on the Steward case, and which brings us together. I will then introduce our panelists, and we'll launch then into a deeper dive into the Steward Health Care bankruptcy proceedings, what led to it, and what lessons we've learned from it. And we'll even touch on some of the statutory changes that have occurred in Massachusetts, although it is a national case. There's no question about that. But each state is reacting to cases, nonprofit. This is a for-profit hospital situation. So in March of 2022, just before the case filed, sorry, I thought I heard something. All right. Just before the case filed in May of 22, a health policy expert, John McDonald, from the T.H. Chan School of Public Health, issued a telling analysis of the Steward Health system, and was among the first to call it a true crisis. The Steward at that time had 9 operating hospitals in Massachusetts, and those hospitals were in such poor financial condition that, according to media reports of the time, there was inadequate staffing, there were inadequate and spotty supplies, and they could not meet the basic requirements of patients. The Globe, and what you're seeing are some headlines that I thought I would highlight from the Globe as the story unfolded, and they're pretty dramatic and a bit scary, aren't they? So the Globe Spotlight team documented at least 15 deaths across the country, including several in Massachusetts, where patients died after not receiving professionally accepted care, and essentially due to a failure of equipment and a failure of adequate staffing. The regulators also found at least 2,000 other people who had been put in what they called immediate peril as a result of these problems at Steward facilities. In a tragic case that people in this room from Massachusetts might recall, a new mother at St. Elizabeth's Medical Center, and this was really the story I think that coalesced the problem with most folks locally. A new mother had just given birth, and she required a particular device in order to stop internal bleeding. That device was not available at St. Elizabeth's Hospital because that device had been repossessed, and the staff weren't aware of the repossession, and sadly, the mother subsequently died unnecessarily. So we're here to unpack what happened, and we're also here to talk about what solutions might be available. So now I get the best part of today for me as the moderator is to introduce our guests, our speakers. It's easy to be inflated when describing folks like these guys, but we truly are honored to have with us today two of the nation's leading insolvency and restructuring lawyers, generally, and certainly in the healthcare and hospital area. And we'll talk more about that in a moment. So Andrew Troop, immediately to my left, is the group leader of insolvency and restructuring at Pillsbury, Winthrop, Shaw, Pittman. That used to be a lot of firms one day, wasn't it? Benefits. And they used to be based in San Francisco. Is your home base still San Francisco? You don't say anymore.
So I can say this: we have no home base.
Yeah, that's what I thought. Yeah, it's called the Globe. So Andrew represents the Commonwealth of Massachusetts in the Steward case. That representation continues, so there may be some things that limit what he can say. But this is not staying advanced when I want them to get to see Andrew. There he is. Okay. So, Andrew has played a significant role in most healthcare bankruptcies in the last 20 years, and also in medical device and drug cases, including the Purdue Pharma case of some note. He was ranked as a top 10 healthcare transaction lawyer, according to Nightingale Health News, and we're delighted to have. And by the way, he's a local guy because his firm's global. He can be anywhere. And so he happens to be here. And we've known him for at least 35 years, I would say, as a fellow.
Lena's not we for 40.
You got me.
Teaching me.
No, me.
Sam Maizel is here from Los Angeles. Sam is a partner at the Dentons law firm in, as I say, their LA office. I think he's the only lawyer that is ranked in chambers in both the healthcare and insolvency specialties. But most important about Sam, from my perspective, is that he's a graduate of West Point. And although he and I are the same age, I'm not challenging him to race me, along the route of the Boston Marathon, because I think he could still do it. And so Sam was in the vaunted 101st Airborne at Desert Storm and at Desert Shield. After West Point, he went to law school and ultimately got assigned through the Justice Department to do some bankruptcy cases in the healthcare space. And that brings us today to where Sam is truly a national figure in everything healthcare insolvency. So the first thing I'm going to do is to turn to Andrew and ask him. I've got a slide up that talks about the numbers, and Andrew, you can let people read that. But could you give us a little background on Steward, including its path forward, from a small Massachusetts group of hospitals to what we saw at the time it filed?
Sure. And as many of you may know or remember, Steward used to be the Caritas Hospitals here in Massachusetts. And it became the first approved for-profit owner of hospitals in Massachusetts. The sponsor was Cerberus. In 40 years, I should get their name right. Cerberus, a big private equity firm. And they saw potential for investing in turning these hospitals around. Over the years, Cerberus wanted out, and they ultimately sold the Massachusetts hospitals to a management-led group led by a Dr. Ralph Delatorre. And over a series of 2 transactions, Cerberus was bought out completely from the Massachusetts hospitals, and Steward Health Care put itself on a path where, not exclusively, though primarily, it was going to acquire and run underperforming, maybe mostly safety net hospitals, though you wouldn't have described all the hospitals here as safety net, but 7 of the 8 you probably would, around the country. And so in 1985, it was the Catholic Hospital transaction. Ralph, who had been a doctor at the BI, as I recall, moved to become CEO at Steward. They turned, as I said, they were trying to turn around the system and seeking it to grow. They sold it to Cerberus. The AG approved the conversion.
From profit to profit,
right? The AG at the time was Martha Coakley, as I recall and look at the dates. The deal was worth most of $1 billion. And then to finance its growth, Steward entered into a transaction which separated the land from the operations, right? And this happens a lot of times, right? You end up with a property company, PropCo, and an operating company, OpCo, but with a difference here in that the purchaser of the land was an unaffiliated entity. Medical Properties Trust, a REIT, right? A public REIT that acquires land or finances healthcare businesses around the world. And you'll hear us talk today a lot about this structure, OpCo and PropCo, and its impact on Steward in particular. But I just want to take a quick aside, because what you may also hear or have heard people talk about is that, well, they bought the property and they leased it back to Steward. And it was a true lease, right? It wasn't a loan. It wasn't an equity investment, although ultimately MPT ended up with a small piece of equity in Steward. But I want you to just keep this in mind. Whether you buy your printer or you lease it, it's a financing transaction. Fundamentally, it's a financing transaction. The law may treat it differently and provide the parties with different rights, but you as the person using the copier, you didn't want to stroke a check for the whole thing. And you enter into a deal where you can use it for periodic payments. If you would have bought it and financed it, it's a very similar transaction. The law treats them differently, don't get me wrong. But the reason this is important is because at the end of the day, you can only service your debt or your lease payments with what you've got. Okay? So just sort of keep that in mind.
Andrew, MPT. So that's Medical Properties Trust.
Right.
Who are they? It's a REIT, Real Estate Investment Trust.
It's a huge REIT. It's headquartered in Alabama, as I recall. It's where it had its
For
start.
those of us that have been around for 40 years, are we talking about MediTrust? Is that the great grandson or great grandfather?
I
No,
don't think so.
no, it's not.
I don't-
Unrelated to
I
the-
don't think so.
Okay.
They just have similar names because if you primarily invest in the dirt under medical facilities, it's like there's a million St. Vincent hospitals. They're not actually connected. They just have similar names.
So Sam, let me.
Sometimes with the T apostrophe R, sometimes with the TS.
Yeah,
You know,
And you have a couple things about what Andrew was just talking about that you need context, right? So when Andrew said that they did the sale leaseback to provide monies to operate the hospitals, that's partially true. Some of the hundreds of millions of dollars did go into operating the hospitals, but the bulk of it went
These
to
hospitals.
repay
these
the chivalrous private equity investors. So you want the context here. That's where the bulk of the money went. And that's, I think, I wasn't involved in the transaction, but my guess is if there was a general catalyst economic driver for why private equity sold the dirt, it was to get the return in a short order to their investors, not to finance the hospitals.
right. And honestly, I don't believe that private equity sold the dirt. I think that the new management-led company sold the
No,
dirt
it was definitely during the private equity.
during the transition.
Maybe.
It was during the transition. But
Well, here's the other thing though. In
before
context,
before you
Andrew and I have done this.
I'm supposed to moderate.
okay, be moderate.
Let's go one at a time.
Okay. So
Minimum standard.
but think about what Sam just said, right? Nearly $1 billion came to Steward out of the MPT transaction based on the Massachusetts hospitals, right? Very little of that money went, if any, went back into the Massachusetts hospitals. It paid purchase price, buyout Cerberus. It made distributions to shareholders. I won't speculate on what got bought by it, but you can all read. And it went to buying facilities in other states, right? So you can imagine for the people here, particularly in the room, ultimately, Massachusetts is a little annoyed that this value, and being tame, right? Annoyed that this value from its hospitals seeped out of the Commonwealth. And we'll talk a little bit more about that as we go through to how people have been responding to this. But I also just want to emphasize that this overall structure, right? Opco, Propco, get money for the land, use it to grow your business, which may not be where the land is, is not atypical. In fact, it's typical. It's typical, right? So, and not to get to the punchline in some ways, but part of what makes this particular case so fascinating and interesting is that this industry, healthcare, particularly hospitals, particularly community-based hospitals, wherever located, they serve a different purpose and exist for different reasons than a widget manufacturer. Right? And that overlay, which we have talked about a lot, is what makes so much of this so challenging.
So the,
Yeah, wait.
Yeah.
One thing though, I also want to put it in context because while this is a really interesting case and Steward is the 800-pound gorilla because of the size of it, it isn't remotely unique. So since Steward filed earlier this year, we had Prospect, 16 hospitals, a very similar business model. They owned the dirt. Private equity got involved. Private equity sold the dirt. And then the hospitals failed because now they lost the value of the dirt and had the additional costs of now paying rent on property they used to own.
And even more similar in Prospect because the real private equity player exited,
Right.
right? Left with sort of the management people.
Right.
And full disclosure, I represent our neighbor, Rhode Island, in the Prospect case.
And then even more recently, Genesis, which owns like 175 skilled nursing assisted living facilities, also filed bankruptcy, also in Texas, although it was not headquartered there. Same model. Used to own the dirt. Private equity invested, bought it, sold the dirt, transferred it back to management, exited after they'd made the money, and now it's in bankruptcy.
Right. And we're going to talk about OpCo, PropCo, like property. But for those of you who have ever stayed at a Days Inn, right? Days Inn did a structure where they put all of their intellectual property in a standalone, allegedly bankruptcy remote entity to support financing vis-a-vis that intellectual property to be used with that ultimately was used to like buy the IP, right? And fund operations. But again, and I'm sort of jumping ahead, it's sort of hard to run a Days Inn without access to the IP, right? It's sort of hard to run a hospital without access to the real estate. All right. And so we're going to do this. And I done my job. He's the moderator, but I see your hand.
Quick thing about
We're fungible here.
the transition from nonprofit. Was there any understanding or proper to the Commonwealth about why this was going to do this part of civil law, or why would they approve that?
Because Sam thought it was a good name. So
So every state in America, the sale of nonprofit assets to for-profit, and I'm just talking about, let's just restrict ourselves to hospitals, is overseen by the state attorney generals, varying degrees of oversight. Texas, not so much. Massachusetts, California, where I'm from, a lot. And in every case, they impose financial and operational conditions on the buyer. That's the trade-off for not having to repay the nonprofit value, right? The AGs impose conditions. So they're going to say, you have to keep the hospital open for 10 years. That's a really common. You have to, used to have 15 emergency room beds. You got to promise to keep 15 emergency room beds for 5 years. You got to maintain these contracts. You got to do this. There's lots of operational and financial conditions are always imposed.
So
That's the trade-off.
yeah, though I think to go back to 1985 or whatever it was, 95. The Commonwealth was stuck in a situation where either at the time, I think it was 9 hospitals that were within the Catholic charity system would close because there wasn't a nonprofit alternative for the hospital. And the impact of the closure of those 9 hospitals, think about the dominance of St. Elizabeth's at the time for Boston, Brighton, parts of Boston, Cambridge, geographically up towards Newton and the like, right, would have been significant. A significant loss, but also a significant drain on and challenge on the remaining hospitals. Keep that in your mind. Keep that idea in your mind because we'll come back.
I want to roll back to the financing because the financing structure, which I know is very easy for you guys to talk about, I want to make sure everyone's getting it entirely, right? Because that's at the root of the problem when we file. All right. Hold on. Let me finish my question. All right. Let me finish my question. So how do you
He
price?
sometimes thinks he's still a judge. It's a kind of bubble.
No, he wouldn't still be in the room. Interrupted me that way back in those days. So anyway, the price, in Finance 101, we look at the operating business. We say, okay, St. E's is producing these revenues and it can afford to pay X dollars back on some form of financing, whatever that financing is. That isn't the way this financing is structured at all, correct? They're not really looking at what are you generating. They're looking at the value of the real estate, correct? And they're looking at maybe some hope about what they could generate. But correct me, how are they establishing what those lease payments are going to be?
I think it's more, there are more inputs than simply the value of the real estate, right? But at the end of the day, if you think you got the real estate and you can do what you want with it, it may influence the level of risk as a lender you're prepared to take on the other factors, revenue growth, projections, and the like. And so there are more factors. If you look at the MBT leases, the rent was originally set and intended to be based on a percentage of revenues. The problem with healthcare is you have entities that are operating at break even or 1%, 2%, 3% profit margins before real estate expenses, right? Before real estate expenses. So there's a challenge when you look at revenues, right? There's also a different perception, right? And there always is, right? With specialized investors, and that's what I'll call MPT, right? A specialized investor. They might look at a business and say, I see real potential in this business and its management that screwed it up, right? Or we could have gotten paid everything, or we would have gotten paid everything. And I'm not commenting on whether that's true or not. I'm just saying I think that's part of the calculus. Yeah, but the challenge is, I think, even if the lease payments were pegged as some percentage of revenue, there's a disconnect between what that revenue actually produces above operating expenses to be able to pay other expenditures.
Yeah.
Is that fair?
Yes. And think of how hospitals are financed, right? So here's the thing. If your lease payments go up and you're running a shoe store, you can increase the prices on your shoes to cover the increased cost of doing business. If you're running a hospital and you're 80% dependent on Medicare and Medicaid patients, you can't pass on the cost because Medicare and Medicaid tell you what they're going to pay for that hip replacement. You can't alter that. And most Blue Cross Blue Shield, Cigna, whoever provides your health care, they peg their contracts these days to Medicare, Medicaid. Their contracts will literally say, we will pay 120% or 130%, which is why when you read about why, Blue Cross Blue Shield pays so much more than Medicare, Medicaid for the same service, it's because Medicare and Medicaid don't cover the cost of the services that they get. So somebody has to make up the difference. So that's a problem if you can't pass it on to Blue Cross Blue Shield, Medicare, Medicaid, who pay for virtually 100% of the medical services in America. You can't pass on those increased costs. And now think about coming out of COVID, increased labor costs, nursing shortage, increased inflation, tariffs when they eventually figure out if they are going to go into effect or not. All those things send costs up, and hospitals can't respond by increasing the revenue. Yeah. Genesis.
On Texas. So helping growing
It-
learn like your core question was is it like how do we move forward knowing that is getting involved? You mentioned that Massachusetts for sure.
Okay.
Right. So there's all this money that was then sent out to other states to buy. And it sounds like there's all these models. What do we do moving forward? What or the lessons learned we achieve?
Gonna get to
We're gonna
that.
get to that. We're gonna get to that, but I'll give you a short answer right now. Massachusetts, as well as other states, have enacted legislation intended to mitigate some of these risks, right? There are other risks that go along with operating hospitals that are not, we're not going to address today and are addressed in varying degrees by different kinds of legislation. But today we're going to really be talking about the risk that goes along with this structure of PropCo and OpCo.
And just again, context, private equity owns very little hospitals. I mean, it's like 8% or less of the hospitals in America are owned by private equity. And the financial issues that these hospitals were facing, that's why the leaseback is certainly a big driver for those entities, but the financial issues that are facing America's hospital systems are endemic.
Right.
So I think that's exactly the point in answering your question. What can be done? What are the lessons that we learned? We're going to talk about that some more in a few minutes. But the reality is that what mostly Sam has described as the state of affairs of hospital finance, not even finance, hospital operations, in this environment where the government sets the rates, private insurance adds a certain percentage to it and uses that as a baseline. This is a problem, right? That isn't going to be addressed, I think, state by state, period, right?
I can't given up trying to prognosticate about what's going to happen.
I asked these guys recently, what's the end result? Where do we go? How do we fix it? They don't have an answer to that. What exactly is it? What kind of a crisis is it? And we don't necessarily have an answer to that. So we're not here to answer that.
We're not going to talk about that today, but when you're ready to talk about that, I'm happy to talk about that.
Yeah, and notwithstanding the different perspectives that we come from, I think we all recognize the challenges here and have some ideas, many of which would not be palatable, right? Just to be clear about it.
But Dr. Stewart,
but
Back to Steward, and I,
yeah,
I
but
do
just
want-
before we do this, just
Yeah.
to throw out one little tidbit, but I can't remember where I read this. Okay. There's a study out there that says we don't have a single solvent rural hospital in the United States.
And that surprised me.
And, you know, to use Sam's shoe,
Shoe store.
shoe store analogy, right? Right. The other way that you try to increase your revenue is to sell more shoes. You may raise the price, but you sell more shoes. Hospitals, I mean, look around Boston. The last new hospital in Boston, leave aside some of the stuff in Brookline right now, was what, the 1950s, the 1960s. The hospital model then was you went into a hospital, you were there for no fewer than 10 days. And the hospital got paid for every single one of those days. Now the push is to get people out really quickly, to move them maybe completely off care, but at least out of the care of the hospital. Has a significant impact on revenue, but it doesn't change the cost of maintaining that infrastructure. Right? So there's so much at play here.
Yeah, this is way beyond the scope of today because the influx of ambulatory surgical centers that strip off all the low risk, high compensation I mean, we can't do it today. So we have to get back to Steward.
Let's go to Steward. And so, Andrew, the phone rings on your desk, and it's the governor or the attorney general of the Commonwealth who says, okay, they filed. I hope they called you a little before that day, but that phone call comes. And we'd be interested in hearing. I've got a slide up that talks about what it looked like, what the financial, the size of this Steward Health Care was on that day. But bankruptcy lawyers talk a lot about first day motions and what you're looking at early on. Can you give us a sense of what you saw from the Commonwealth's perspective when the case was filed?
Sure. So by the time the case was filed, Massachusetts had decided it had had enough of Steward. And more importantly, in many ways, Steward had decided it had had enough of the Commonwealth. And you might hear me say that and think that it created a particular moment of antagonism at the time of the filing, but it actually presented an opportunity for alignment, which was how will the Chapter 11 be used so that Steward can exit Massachusetts with the least amount of negative impact on the provision of healthcare within the Commonwealth. That is not to say that they were fun conversations or not heated conversations, right? But it is to say that it created a framework, but it also created some challenges. First day hearings in bankruptcy are, so I'm going to give you bankruptcy, this part of it, in like 20 seconds, okay? Pre-petition, you file, a wall goes up, you got post-petition, right? And you're not supposed to worry about pre-petition obligations or debts under the bankruptcy code until you get to the end of the case and you know you're going to confirm a plan. And that works just about as well as trying to push water up a hill, right? You have to create a bridge between the pre-petition period and the post-petition period so that the transition to being a debtor in possession is the least disruptive on operations as you can make it. So the first day hearings in the case are really focused on what kind of relief do you need to make that kind of transition. Do you have wages that you didn't get to pay that you need to pay, pre-petition wages? Do you have taxes that are owed, which you may or may not pay? right? Do you have critical vendors that you have to pay who could not supply something? Really important. And then how are you going to finance it? And it is that last part where there is often the most challenge, because the lender wants to insulate itself from any claims by extending more credit or allowing the use of its collateral. And it wants to have control over the process so that it doesn't get unknowingly deeper in the hole. Okay. Other people want to get paid. And other people, like the Commonwealth, have a variety of interests that span that. So on the first day, it's a huge case, as Frank said, right? There were $9 billion in identified liabilities. The case ended with $11 billion in asserted unpaid post-petition obligations. I'm sorry, priority obligations. $2.3 billion in asserted unpaid post-petition obligations, and much more than $9 billion in asserted unsecured pre-petition obligations. There was about $1.5 billion of secured debt out there. There were lots of unpaid wages. There was a lot owed to vendors, many of whom were critical. They were grossly in arrears in their rent to MPT. And they were operating by a shoestring when it came to cash and liquidity.
Did anyone step up to offer financing, at the first days in order to bridge this problem?
So there was a Medical Properties Trust offered some very limited financing, and they wanted extremely broad releases, as I recall. They had two tranches of secured debt. They're called the FILO lenders, first in, last out, and the ABL lenders. They had differing pools, but also overlapping pools of collateral. And they had been resisting putting any more money into the case. They had done some funding pre-petition. At the end of the day, no real money was taken from MPT, and they didn't get a release as a result. There was money taken from the FILO lenders, but pretty much at this point or closely after that, the FILO lenders were unwilling to put any money into Massachusetts operations or hospitals because those hospitals were going to be sold and they were or shut down, and they were sure they weren't going to get a return on their new money. The Commonwealth got asked to fund the hospitals. And the Commonwealth, but nobody wanted to let the Commonwealth fund like a DIP lender and get all the protections that go along with being a DIP lender, like having senior lender control over the assets here in Massachusetts. Plus, you still had the problem that Steward could only offer as collateral the OpCo assets. You still had to deal with the fact that somebody else owned the real estate. So not to spend a whole lot of time on this, the Commonwealth did figure out a way to advance funds, but against future claims against the Mass Health System. There are monies, and there will be a dispute in the bankruptcy over whether the amounts that have not been paid on claims by the Commonwealth can be used to offset the amount that was advanced. And that's for another day and another time, but that dispute is pending.
You, with any effort, you might get to the clawing back money that was advanced to the Steward principals when they get a private equity
We'll get to it.
You can answer it now, but
And the answer is there is a lawsuit filed. It was filed recently by the liquidating or litigation, I forget the name, trust that was formed under Stewart's confirmed plan of reorganization. They filed lawsuits against Cerberus, against principals primarily at this point, for a variety of claims arising out of multiple transactions.
two footnotes that I want to get to, but they're significant. But first, I'll make this comment just to bring it into focus, right? If you're the bankruptcy judge, in comes a healthcare debtor. You have something that you have in almost no other case, and that is patients that are in that hospital or in that nursing home, so that although the lenders might come in and say, Judge, you need to convert this case, you need to appoint a Chapter 11 trustee, or take these scoundrels out of control of the case, first in your mind has to be, what about those people that are still in that hospital? This is not a shoe store, right? Where I'm sorry, we have to shut it down and we'll have a liquidation sale and the owner will go on, to do something else. But this is a situation where the patients have to be foremost. And in fact, in 2005, the bankruptcy code started to require a healthcare, as a proxy, what do we call it?
Patient care
a-
patient care ombudsman.
A patient care ombudsman. And that patient care ombudsman comes in and represents those patient interests, right? To make sure the judge understands, what's going to happen. We know another thing on the acute care hospitals, obviously are a very significant problem. But in the nursing home cases, we know that when you start moving people, they're probably not going to, I shouldn't say everyone, of course, but a significant portion of that population will not survive a move, right? And so the judge now is faced with, I got to keep my finger in the dike long enough to maybe get a buyer in here. And I hope that I got really smart lawyers, and I mean that. Like these guys who understand all that are going to come in and help me get there, right? Okay, that's from my perspective. But Sam, I want to ask you this. It's a footnote, but I think it's significant. This case gets filed in Houston, Texas.
Yes.
Were there assets in Houston? How does that happen? Why Houston?
Well, the advantage of having a large national health system is you could probably get venue virtually anywhere. The last few years, Houston, Texas has been the jurisdiction of choice for bankruptcy lawyers for a lot of reasons, also beyond the scope of today's program. There is also a judge in Dallas who is very well thought of by Alvarez and Maizel Healthcare Group and other large healthcare advisory groups that provide the chief restructuring officers for major companies in the healthcare space. They like this judge, and so they file in Dallas or Houston. And Delaware is still gets a good share of cases, but not like it used to. And those courts are, it isn't that the fix is in for the debtor, although creditors might disagree sometimes. But the courts have processes that make it possible to run a large Chapter 11 case much more efficiently, which actually there is some benefit to creditors because it means less expenses, less time in the bankruptcy proceeding. But yeah, I mean, Dallas and Houston,
Who picks the place?
the debtors' counsel.
Debtors counsel and
Well, I mean, the client theoretically picks the venue, but I
right.
mean, they're frequently follow their lawyer's advice.
All right. And
Who are frequently following the lender's suggestions.
True. That's
Right.
also true.
okay. And another, Lena,
Yeah, it's one question. You're indicating that the root of this problem may well be sale-leaseback transactions, but are you saying that in the context of sale-leaseback transactions generally, or only in the context of healthcare? Because if you have price discovery, if you're able to adjust your revenue stream
as your rents escalate, then the issue isn't really the structure of the transaction, but rather what happens with the money that you get from the sale, and then how rapidly can you adjust your revenue stream to meet your obligations under the lease. In healthcare, you can adjust certainly where that money is by
Where it goes.
by conditioning any approval of nonprofit to for-profit on restricting the flow of the funds realized from any sale. But that compromises your ability to get the financing aspect of a sale leaseback. And there isn't going to be bank financing at affordable rate. So if you allow the sale leaseback in the healthcare area, where you have these conversions from nonprofit to for-profit, you're between a rock and a hard place. Either you eliminate the sale leaseback, in which case you don't have financing, or you allow it to go forward and you have no control over pricing your services to be able to adjust for rent. So it's a problem with our healthcare system more than a sale leaseback.
Well, that's right.
structure.
I don't think it's.
Lena, you need to get a chair and come up because you just summarized the problem.
That's spot on. But I want to go back to the first thing you said, which is it's the root.
Right.
The root of the problem with healthcare is not, sale and leaseback is just like a thing. And it certainly contributed here and in those other cases. The root of the problem is how we deliver healthcare in America. It's like, yeah.
And it's exacerbated here in this case, in my opinion, because in most, but in many of these OPCO-PropCo structures, the ultimate equity owners of both businesses are the same. So they have some aligned interests. The challenge here is that they're owned by different people with different views and their own different constituents that they have to answer to. So you layer that on top of this poor delivery system, and it becomes more difficult. We've gotten to like the third slide.
No, we're just past first day motions. I think we're at about noon on the first day. So, I do want to get it into the path of the case, the transition of, since we're in Massachusetts, I want to focus on Massachusetts, but can you dig in? Get under the hood, Andrew. What are you doing now? What is the debtor doing to try to ensure that these hospitals either, well, if necessary, get closed or get sold or adjudicated in some fashion to move forward?
So the Steward had started a sale process before they entered into bankruptcy. The process that they used may or may not have been the best, right? They divided Massachusetts basically in half, the southern hospitals and the northern hospitals. They had different investment bankers for each, right? And they tried to find buyers. They weren't able to do it as of the day of the filing. And that process continued, but so did the challenges to the system itself. So it's more complicated, but Norwood was a Steward hospital. It was closed because it had been flooded.
It had already been closed, right?
It had already been closed, wasn't operating. There's a lot of discussion about whether anyone could ever open it again, do whatever again. There was that. Ultimately, the Kearney and Neshoba closed. No one was happy about that, but people made tough decisions based on data. There wasn't going to be an operator for either of those hospitals. At both of those hospitals, census was very low and not likely to be to rebound in the near future. But at the same time, both of those hospitals were centers to their communities. right? And so that was going on, but the Commonwealth got involved, right, at the request of the debtors and other parties, trying to figure out how to sell these hospitals into. And ultimately, three entities showed up to take over the remaining, call them 6 hospitals, right? Lawrence General, Tufts, Haverhill in the Lowell area, right? And Lifespan, which is now Brown out of Rhode Island, Good Sam in St. Anne's, right? And BMC, St. Elizabeth's, right? In one other hospital that just, the name I just lost. And these were tough negotiations because of all the things we just talked about. These hospitals, all nonprofit, the highest percentage of public pay patients in the Commonwealth. So that whole disconnect between what you're getting paid and what it costs you being exacerbated, couldn't pay a lot or much. And it was different by hospital and different by system. But after lots of fits and starts, those hospitals were all transitioned to those 3 entities, not without some hiccups and not without some other battles, but they're there and they're operating today. So it preserved jobs, nurses kept their jobs, counterparties kept the contracts or these relationships primarily, and patients kept their hospitals. And at the end of the day, that was a Commonwealth's goal to do that for as many of those hospitals as could happen.
With a least patent restructuring.
So, really good question.
What happened to MPT essentially? What? Go ahead. Yeah.
So another layer of complication. MPT needed to borrow money to make its $1 billion payment to Steward. They borrowed it from Apollo. Apollo was the mortgage holder on each piece of property. And ultimately, there was the resolution was that whatever cash consideration came out of the deal went to Apollo. There was an overall settlement in the estate with MPT. They walked away from their leasehold interests and got some releases. And the new owners own the buildings and the property, Opco and Bronco. But almost. There's still some things being worked out, but we're not directly involved in that, so I'm not talking about it.
So just 1 second, the upshot, and we'll get to the punchline now, and that is that, as Andrew has already mentioned, there was a plan was confirmed. It's a liquidating plan, right? So all the hospitals were either sold or closed. And I have that right, don't I?
Nice.
There's nothing left in the estate. And so what happens then is there are claims, though, that are available to the estate and there are people who haven't been paid. And so the hope is that this liquidating trustee or receiver or whatever that fiduciary is will now go out and try to collect on those. We can talk a bit more about those. That's what's happening on this very day. But I cut you off, Sam. Were you going to say something?
Sales, because look, selling a hospital in bankruptcy is fairly a difficult task because they're financially underperforming. You got to find somebody who's willing to take that risk on. With regard to the conditions, there was a question earlier, and I talked about the conditions the AGs imposed. The attorney generals take the position that those basically run with the land, and so that the next buyer has to assume those same conditions. In cases that I've litigated against the attorney generals, opposite sides of this argument, we've used the bankruptcy code to cut off those conditions, and we were able to keep hospitals open that otherwise were radioactive in the sale because the conditions imposed by the Attorney General made them operationally, financially non-viable. Sliding those off in the context of a sale free and clear in bankruptcy, people were willing to take on the hospitals and keep them open.
But in Steward, I will say, as it relates to the Massachusetts hospitals, there were not additional conditions imposed in connection with the sale.
But did the old conditions run with the hospital?
Well, if you want to say the old license conditions, like your license requires
No,
you
not
to have,
the conditions that were imposed in the sale from the not-for-profit to the original for-profit.
so, to the original
Yeah,
for-profit.
because the AG imposed conditions when it first transferred
Yeah,
from the not-for-profit to the for-profit.
that was not an issue in the Steward case, right? That is an issue in the Prospect case, but not an issue in the Steward case. There was no debate over with regard to the Massachusetts hospitals, with regard to the continuation of conditions. And I think, frankly, a lot of that has to do with the fact that the buyers here were predominantly Massachusetts not-for-profit hospitals and hospital systems with their own relationships and understandings with Commonwealth.
I need to exercise some judicial control because we're almost at. So I want to make sure that we get any questions, but I have two questions to ask, one of which you could spend an hour on, but I ask you not to. First one is something that Andrew probably should plead the fifth on. And the other one, and that question, I suspect Sam might not be able to answer, but I'll ask him. Do you know what you know of Steward? And maybe what you know of other hospital insolvency cases similar to it? What did in this case, I guess I'll say the AG, what did the government do right? And what did the government do wrong? Or is that a fair question?
It isn't really a fair question. I'll tell you why. I mean, I litigate against the attorney generals all the time. I mean, I formerly was at the U.S. Department of Justice, where I represented the Medicare program all the time. Because there isn't really a right answer here. That's I think that it is. I get the attorney general's position. They are imposing conditions that they believe, for lots of reasons, are important to the maintenance of the healthcare system. When I'm selling a hospital and I'm trying to find a buyer to keep it open, my viewpoint is I need as few restrictions as possible to make it as an attractive target. I litigate against them, not because I think I have the high moral ground here or I'm intrinsically right. It's because I'm trying to do what I paid to do, and they're trying to manage healthcare. We've decided to deliver healthcare in America in a very Rube Goldberg-esque way, right? We've got government, we've got not-for-profits, we've got for-profits. Now we have private equity increasingly. We've got, small, big hospital systems. This is what you get.
Right. Then my last question before we open it up is, this is for you, Andrew, and there it is. We want to know, what did it cost taxpayers? And maybe that's still not a number that's finalized, but there's some costs that went into this. You talked about some really post-petition financing that the Commonwealth did. Some monies were owed perhaps to, in each direction, pre-petition. What happened? What's the ballpark number of what this cost taxpayers?
So the way the question's asked is, I have no idea what it's going to cost you or me, right? But what I can say is that to keep the hospitals open, for example, during the Chapter 11 case, the Commonwealth figured out a way to advance, subject to recoupment and offset rights, which are being litigated, about $70 million to make sure that wages got paid and supplies were in the hospital, right? To fill the gap between the operational revenue and the operational expenses. And And the Commonwealth has made clear its intent to support not only these hospitals, but hospitals throughout the Commonwealth who are dealing with challenging healthcare delivery issues. And it's hard to put a number on that. I mean, but you can, but you know that these hospitals had some significant problems that are going to require dollars to fix. They had infrastructure problems. The PCO issued her first report, maybe it wasn't her first report, but she went to visit St. Elizabeth. St. Elizabeth, as I recall, has something like 16 elevators, right? Sort of half of them were working, right? Elevators are a big deal in hospitals, right? And you gave the example of repossessed critical medical equipment. There has to be investment in medical equipment, right? And the Commonwealth is, I believe, based on public statements, committed to trying to figure out a holistic approach to this provision of healthcare, which is just getting harder given everything else that's going on at the federal level.
Is the bankruptcy
Right.
system the right place to no, too big a question.
No,
Let's not go there. Let's answer.
What Andrew just described, Massachusetts is probably the most benevolent government of the 50 states with regard to trying to prop up failing healthcare entities. I mean, it's not just the Steward hospitals. Haywood was in bankruptcy, not that far outside Boston, and they propped it up until it found a buyer. California is not, I mean, all states manipulate streams of payments to hospitals to keep them afloat because Medicare and Medicaid don't fund the cost of care. Those failures have to be made up through disproportionate share payments, directed provider payments, and a stream of other ways that state governments can funnel money to keep their hospitals open. You know, Massachusetts is just a little more direct about it when they're actually like giving grants than other states. And there are lots of states where they just go, I guess we're just not going to have a hospital here anymore.
And the state also wants to, and has enacted legislation in January of this year, right?
Thank you. Yeah.
To, I'm going to use my generalized description of it. The specifics are very different, but it's to keep money that is spent or paid for healthcare in Massachusetts and directed back to that process. So you can't have opco-propco structures really anymore. Private equity has disclosure and other requirements so that issues about dollars can be identified more quickly. There are fines and penalties imposed on a daily basis for failure to perform. And it is at its core, right, a combined reporting and some limitations on operations and ownership kind of legislation. And it jury's out on how it does or how it works, right? It's still got to be implemented, regs, all those things that go on. And I'm not going to talk to the end because you're dying to
Go ahead.
Risks group, the biggest low reporting is and you were reporting requirements that would go to Massachusetts government agencies, maybe about whether or not these payments were paid on time, KPIs, many things that were actually required either through legislature or not, that were not provided annually and permitted to, and went ongoing, perhaps even before the 2022 Harvard analysis. So that's so is it not that there were many things in this transaction with Steward and fulfilling their with the medical properties trust and reports that were not filed and continuing about it, and it wasn't overseen. Could you talk to what was required but what was not done that would signal red lights earlier?
So I can't provide you with details on that because I wasn't around then.
Yes.
But what I can tell you is that the Commonwealth sued Steward in order to compel it to provide financial information that it was required to file. That lawsuit went on for 2 years before there was a close to final determination that would have required them to provide effectively audited financial information. That was in May of 2024 or sometime in early 2024, when the decision was rendered. Steward did not immediately comply, and it filed for Chapter 11. The challenge that I think all of us have had as practicing lawyers is that a statute can say something, a contract can say something. If the other side doesn't want to perform, your ability to enforce is not snap and finger. And so I think that this new legislation, in part through its imposition of daily fines, is intended to ratchet up the downside of not complying, to be beyond just being obstreperous in legal fees. It's also empowers and provides that in the absence of certain information, licenses will not be renewed. It goes much more directly in terms of what the remedies are. Part of the lessons from this case.
Yes.
Thank you folks for being here. Welcome again to Sullivan. I'm a tax lawyer by training, and I guess as I think about sale leasebacks and lease financing, we know from other examples like student housing or government office buildings that REITs can be involved, or they can do sale leasebacks, lease financing, and those things, they don't have to blow up. The student housing doesn't blow up. Government office buildings don't blow up. People are able to make their rent, pay their rent. So if we were to rewind this movie back to the original financing transaction, and if it sounds like it was done in a context where these hospitals were already under financial stress, and this was supposed to be the way out of that stress, to get some financing, maybe to put the money back into the business. How if you could rewind the movie and play it back again a different way, how does it have how would it have a different or better ending than the hospitals not shutting down?
Yeah, I just would challenge your assumption that this was about putting the money back. I don't believe that. I believe that this was about private equity has a shorter window than a hospital in terms of getting its promised generous return to its investors. And the way they did that in these investments, Genesis, Prospect, Steward, and others, is to sell the dirt and take that money to return it to their investors. That's my belief where the bulk of the money went. And the only reason any money went to the operations or to other things is because they had to maintain the loss. That it wasn't all just about getting a huge return on their investment.
So
We're gonna one more. This is really it. So
It's hard.
go ahead, Eric.
Very think about the same question, which is if I when it's husband service dues, I say to myself, okay, the $100 that I make in revenue, maybe I said like $1 or $2 of profit from that if I'm lucky. So one way to think about this is the value I'm going to sell at, net present value of those funds flows with some sort of trade in some way, or less. But then you also say, okay, wait a minute, there's another source of value here, which is this power. And I'm going to want to add that. And so whether or not I have an opco propco solution, which one way there's value from property. The other way to do it is to build that into the purchase price and say, look, you're gonna have to pay for this asset. You go for it, figure out how to make this work with the buyer. Right. And if the buyer, so the opco propco is a solution to solve that problem. But if I in Cerberus's views, why would I sell for anything less than at least some approximation of the value of the asset that attached was?
You may not want to sell for anything less if you, in fact, can separate the property from the operations of a
Right. And
right. That's so I think the question is framed assuming the answer. I can split it, and therefore I want the value either way. And I think the question here fundamentally is by allowing the splitting of the property and the operating company, are you in fact inflating the amount that the operating company has to generate in order to actually operate? Right? That's right. So, and again, that's why this case is particularly challenging because healthcare is different than a widget manufacturer.
All right. So Andrew has a hearing in Delaware in 12 minutes. And I promised him that I would get him back into a room where he could do that. But we could do another hour and a half, couldn't we? Very easily on this. But we'll post the slides. There is some description of the new Massachusetts statute, and I hope we have demystified to some extent, what happened in the case. And I thank our presenters today for
Well, thank you
thank
for
you for your
inviting us.
questions. They're
Nice to meet you. No.